When I was about 18 years old and thinking about going into med school, I had a sort of a secret dream, and that was to be a movie director. So you know, Peter and Tom, what you did now is to just make my dream come true. You invited me to come to LA in the middle of winter, and you invited me to come to the stage and deliver a speech in Hollywood. Although this was not really exactly what I was thinking about when I was dreaming about being in the movie business, I'm quite excited about coming here today and talk to you about anemia and non-dialysis CKD. And I actually put this title here, and Quo Vadis, as Tom just alluded, means where you're going in Latin. But actually it was a movie released in 1951, starring Robert Taylor and Deborah Kerr. It ran for 8 Oscars, just one, and actually saved Metro-Goldwyn-Mayer from bankruptcy because it was a huge blockbuster. So a lot of movies in this introduction here today, and thank you so much for inviting me again. This is such a great meeting. I enjoy it every time. So the very basis about anemia, and that's where I want to start my talk with, is that both erythropoietin and iron are very important in red blood cell production. So this has been the basics of the way that we understand the mechanisms behind anemia in CKD and in other diseases too. And also, it has based the way that we manage patients with chronic kidney disease, both in the non-dialysis space and also after dialysis initiation. So it was produced by the kidneys, and iron travels from dietary sources or supplements to the bone marrow via the circulation, promoting through EPO promoting erythrocyte survival in the bone marrow, producing red blood cells that matured if enough iron is available. When you introduce chronic kidney disease, and that's very similar in many other inflammatory diseases, this mechanistic model for red cell production changes a little bit. And the main changes is that the inflammatory process promotes hepcidin production by the liver. And this really shuts down the way that usually our body brings iron from the gut or from the endogenous iron resources. Also, chronic kidney disease seems to lower red blood cell survival, and also directly decreases the capacity of erythropoietin to generate or to mature red blood cells in the bone marrow. So that sets up the stage and sort of defines the challenges that we have when treating patients with chronic kidney disease currently, and really limits the possibility for excellent results. So in 2020, the way we treat patients is actually to provide enough iron substrate and to give patients ESA supplementation. So treating patients, or even patients who are spontaneously at higher levels of hemoglobin, they seem to experience better outcomes. And this has been quite clear in the observational space, that patients with higher hemoglobin, they have better outcomes. This is perhaps one of the most recent observational evidences that support this concept. This came from a project that I'm leading currently in Michigan called CKDOPS, is an observational study of nephrology practices around the globe, including 5 different countries. And this is based on about 11,000 patients that have been recruited so far and followed for an average of 2 years. So you really can see here that when hemoglobin rises as a consequence of treatment, or just because a patient is not anemic, this is associated with a decrease in the progression of CKD and also with a decrease in all-cause mortality. And this actually goes along with previous observational evidence going in the same direction. That perception that the higher the hemoglobin, the better this is for the patient, motivated us as a community, nephrology community, to change the way we approach patients in clinical trials from the bottom of this table here in the late 80s, all the way until the more recent trials, mainly trials with the ESAs, to be more and more ambitious about the target, the higher target that we put patients in the intervention arms. So look down on the bottom in 1989, one of the first trials with ESA. The placebo group was kept on in a hemoglobin of around 6, and the intervention group targeted hemoglobin and achieved a hemoglobin of 8. This would be something that would be impossible to do today, mainly because of the studies in the main 90s showing the benefits of putting patients into a hemoglobin target around 10 to 11. And that was the current status in the 90s. And then after a while, we were audacious enough to go and try to normalize hemoglobin. So that was the intentions of studies like the BESSERAB study in dialysis patients, and TREAT, COIR, and CREATE that were all based in non-dialysis CKD that really challenged the concept that, of the potential benefits of normalizing hemoglobin. And this is just a summary of the results of the trials that try to normalize hemoglobin. You see the BESSERAB trial in dialysis patients and all the other 4 major trials in non-dialysis population. They really achieved their goal of normalizing hemoglobin. The average hemoglobin for all those studies is around 13. And what was a surprise to the community was the fact that consistently all of those trials actually showed some benefit in terms of patient-reported outcomes, improvement in quality of life, but almost consistently they also showed an increase in cardiovascular risk. There really was a bit of a disappointment in the community, that sort of reshaped the way that we manage patients and we target hemoglobin in patients in non-dialysis and also in dialysis chronic kidney disease. So here's just a summary of what those trials showed us and established the current status of anemia management in terms of ESA treatment. The perception that these supraphysiological EPO levels might be not so like a good thing to try to achieve. Also the fact that to do that, sometimes you need to have higher doses of ESAs, and that generates fluctuation in hemoglobin, particularly in patients with comorbid conditions, hospitalized patients, and that might be also harmful. And that generated a concept that, let's face it, is the way that we treat patients in terms of ESA and decisions on to use ESA. We are really trying to help to prevent or minimize the need for blood transfusions. It's kind of like a sad story for the end of this era of ESAs, where we really thought that we had the capacity to normalize and to improve life of our patients. The other side of the coin is iron. And I'm just here summarizing because we do not have really the same evidence in terms of iron supplementation and hard outcomes. Most of the trials in non-CKD and in dialysis, other than pivotal trial, of course, they actually had the main objective of sparing ESA and increasing hemoglobin. That was the objective of iron supplementation. And I'm gonna challenge this concept during my talk today. So really this, we supplement iron today, and this is in the guidelines, to increase the iron levels necessary for hemoglobin production. And what we use as an outcome for most of the studies, especially in non-dialysis CKD, as a primary endpoint is increases in hemoglobin. And the only trial that challenged this and had a primary outcome to reduce cardiovascular outcomes is the pivotal trial that is done in dialysis patients. And I think we've been successfully treating patients in trials, but what you see in the middle of my presentation is that perhaps in real world, we are not doing that great in terms of really using these concepts that came from trials and they are included in guidelines in terms of recommendation of management. And then we go back to the CKD study. And then looking at the baseline of the study, of the observational trial in 11,000 patients in 4 different countries, Brazil, France, Germany, and the US. This is what you see in terms of the hemoglobin distribution by CKD stage. So this is a mix of patients treated, not treated, under investigation, starting nephrology follow-up. But it's a cross-sectional analysis of how hemoglobin is distributed across countries and across CKD stages. So it's very clear, and this goes along with previous observational studies that show that the prevalence of anemia increases with the progression of kidney disease. And that, especially when you look, and I'm going to be focusing on the US, when you look at patients on stages 4 and 5, there's a very high proportion of patients with the hemoglobin levels below 10. It reaches about 35% in the US, patients with hemoglobin levels below 10, and those are patients that most of the time we're considering treating or initiating treatment. So in CKD clinics across the globe, anemia is prevalent, it increases over time, and is highly prevalent. And this goes along, I mean, this observational study based in nephrology clinics goes along with broader cohort studies, like studies using the Medicare population or studies using commercial payer databases, all showing that the anemia is quite prevalent in undertreated in patients with CKD. Moving to the iron deficiency, because we really treat this in separate ways. Patients with CKD in different stages and at different hemoglobin levels consistently show a high prevalence of iron deficiency. So here for this study that was just published in CKD, we actually used the parameter based on ferritin and or TSAT for the diagnosis of iron deficiency. A ferritin below 100 and a TSAT below 20% was used. And when you use the combination on those criteria, we see that about 50% of patients with CKD presented with signs of iron deficiency. And you can see here that the iron deficiency prevalence doesn't change a lot according to CKD stage or even according to the different ranges of hemoglobin. So it seems like iron deficiency is highly prevalent, even in patients treated by nephrologists, and that the prevalence of iron deficiency really doesn't change a lot as kidney disease progresses, as you can see for hemoglobin. So really a different situation when it comes to this other disturbance related to anemia. And this goes along with data from Ann Haynes from the American population that also shows very high prevalence of iron deficiency. Okay, so what I showed you so far is that, you know, we now understand mechanisms of anemia in chronic kidney disease quite well. We do have drugs available, iron supplements or ESAs. We do understand the targets and we do understand the importance of treating anemia, but still when you move to the real world, as nephrologists, we're really not doing a good job correcting iron deficiency nor putting hemoglobin at the targets that the recommendations that are almost 10 years old that are telling us. But what are patients thinking about this? And I think this is something that became like the center of many of the discussions that we have today and we'll have tomorrow too. And actually, I'm not going to go into details about what the current vision of how patients see symptoms and problems in their life, because we'll have a plenary on Friday by Alison Tong, who actually leads this data that I'm going to be showing you today. But just to really put patients' perspective into this discussion about anemia treatment, and just trying to understand how important this is for those patients and what symptoms related to anemia might be the ones that patients wanted to be corrected. And you can see here, this is based on Song HD. This is a project that I was involved when I was in Australia in my sabbatical, and really changed my life as a clinician and as a clinical researcher. Because what these researchers are doing are really, in a systematic way, approaching patients and caregivers and asking them what do they want from their management, from the treatment, and what are the priorities for those patients. And it's quite impressive for dialysis patients, for instance, that fatigue comes as number one. That's the number one factor that came out of the studies based on the Song Initiative in terms of what is the most important thing for patients. This comes even higher than mortality. And this differs completely from their evaluation of the nephrologist perspective. They usually put mortality and hospitalizations at a much higher priority compared to symptoms like fatigue. So fatigue is very important, and anemia as a problem for patients actually comes in the second tier of the Song evaluation. We just showed that connection between those two things, anemia and fatigue, which is probably a symptom that is highly related to anemia, are top priority for patients. So this is hemodialysis. The project on CKD is ongoing. And this is preliminary unpublished data that Alison allowed me to share with you today about the situation or the priorities from a CKD non-dialysis patient's perspective. And you see here that fatigue is not as high as it was for dialysis patients, but appears as a top 5 priority. And that shows that also for non-dialysis CKD, anemia and fatigue are quite important. So I told you that very few trials in non-dialysis CKD really use the PRO, a patient-reported outcome, as a primary or even a secondary outcome in anemia treatment trials. But they are included at exploratory or secondary endpoints. And therefore, it's possible to put this data together to look at the impact of treating anemia, here in the case of ESA, on patient-reported outcomes. And what really stands out is what gets better when patients are treated to a higher hemoglobin level in trials with ESAs, that the physical functioning part of the quality of life of patients is really what changes. And if you look in the top there, you see some trials of very strong impact, but if you move lower and you see the changes in the physical component of the quality of life assessments, you get about five points in improvement when you treat patients to a higher hemoglobin, which is what we usually consider clinically relevant. We actually went more specifically, and this is a meta-analysis that we submitted recently. It was done by Murilo Guedes, who's actually here at this meeting, that put together the trials that with treatment with ESA that monitored or had included as an outcome fatigue, the specific component of fatigue. And you can see here that even a more consistent way, the trials are actually showing benefits in terms of reducing fatigue when patients achieve a higher hemoglobin levels. Effect sizes here are not as big as the previous one, perhaps because not many trials are actually reporting. And just to remind everybody, this is what Song wants to do. Song wants to actually make sure that every single trial in CKD includes fatigue as an endpoint in the trial, at least not as a primary endpoint necessarily, but at least as an exploratory endpoint. And the final thing that I wanted to comment with you is also some data coming from CKDOPS in our analysis in Michigan by Murillo, is that we're quite impressed when we saw this data that we're going to present at the ERDTA meeting, when we looked at not at a change in hemoglobin, but a change in TSAT as a potential association with better symptoms or better quality of life. So what we did here is actually separate patients according to TSAT, lower than 15, between 15 and 20, 20, 30, or 30 and 50. And then we looked at the closest evaluation of quality of life that we had in the CKD patients. And there was a significant association between lower TSAT, lower than 15, and a poorer quality of life, particularly in the physical domain of the SF12 in this evaluation. And this difference and this improvement in quality of life, the physical component and quality of life at higher levels of TSAT was actually independent of hemoglobin, which really points to something that's quite clear in the heart failure literature, that the body needs iron for the muscle function independently from the level of hemoglobin that the patient is achieving. And that might change a little bit the way that we see iron replacement and iron therapies that could be a bit more independent from just targeting higher hemoglobin when you treat patients with iron as a main objective of the therapy. So this is what we are at the moment in terms of ranges of hemoglobin. This is still the way that we are treating patients and defining targets. So at higher hemoglobin levels, there is some sign of harm at the normal levels, but at least no mortality or morbidity benefit, and the risk is variable across the trials. I think most of us are convinced that higher hemoglobins will lead to better quality of life, but with the limitation in hemoglobin that we have, the way we treat patients today with ESAs and iron, achieving the levels of hemoglobin that might lead to a better quality of life might be difficult. And what we're seeing here is that transfusion requirement will reduce when you target to a higher hemoglobin, and that's nowadays the main driver for us to treat patients to a higher hemoglobin is to reduce the risk of transfusions. And KDIGO recommendations from 2012, they recommend something like 10 to 12, not above 13 for the target range for hemoglobin in anemia management. So how are we treating patients? Going back to CKDOPS and looking at the 4 countries again and the different stages of CKD. So this is what we can see here in terms of anemia treatment by country and by CKD stages at the baseline of the study. You see that most patients are not treated at all. The number of not treated patients in the gray bars, they decrease as CKD progresses. And what you can see here that most patients in non-dialysis CKD, they are treated with iron only. And a small fraction of those, which increases over time with the progression of CKD, small fractions are treated with ESA only or a combination of ESA and iron. So really iron, especially oral iron, is the main form of therapy in the real world CKD clinics. So even in CKD stages 4 and 5, treatment of anemia is not a norm, and the lowest prevalence of treatment is in the US. And that goes along with data outside of nephrology from Medicare analysis showing similar under-treatment observations. Scary thing about this is that in CKDOPS, transfusion rate was 22% in first year in nephrology clinics. As a clinician, I was very impressed about this because I think it's a lot. I mean, 22% of patients were transfused after 1 year in non-dialysis CKD. This is quite a high prevalence, especially if the main aim of treating patients today is to avoid transfusion. We're not doing a good job. Other thing that was quite impressed, and this I was quite impressed about, and this is work by Marcelo Lopez, also from Michigan, based on the CKDOPS data, which will be presented in Italy at the ERDTA later this year, is longitudinal behavior of prescription of anemia management drugs over time in patients with non-dialysis CKD. So you see here that in the first column, you see the distribution that I just presented, mainly oral iron as a treatment. But you see here that over time, less and less patients are continuing on treatment. So treatment discontinuation is also a phenomenon that is observed in non-dialysis CKD in patients treated by nephrologists. So I'm going to end my presentation in the last 5 minutes just providing a little bit of the Quo Vadis part of this. Where are we going in anemia? And thinking about, hype and thinking about the Hollywood type of stuff and red carpet and things like that. What a year for nephrology, right? When you have, for the first time in history, a nephrologist receiving a Nobel Prize. So that really was a boost in our ego to see Peter Ratcliffe, a nephrologist from London, being awarded the Nobel Prize in Physiology and Medicine in 2019 for the first time in nephrology history. And he received this award for his discoveries in how cells sense and adapt oxygen availability. The reason why I'm bringing this to transition to the last part of my talk is because this actually generated in the recent years a better understanding of the pathophysiology of anemia in CKD and also outside of the CKD space, but also led to the development of new therapies. They are now coming to the prime time. So this is the way that the understanding of oxygen sensing changed that graph that I presented to you in the beginning of my presentation. So other than the typical involvement of ESA and iron in the process of making red blood cells, we now understand that the liver and the kidney, they are capable of detecting hypoxia through some proteins called the HIFs, hypoxia inducible factors. And stabilizing or not this protein allows for people to really regulate hemoglobin production. And really justifies why people at low oxygen levels at high altitudes, people in Colorado, for instance, like we just heard from Isaac earlier in the morning. And really this production of these HIFs, or the stabilization of these HIFs, leads to the production of endogenous EPO. And that really leads to increasing hemoglobin. Also, interestingly, the same protein actually is capable of targeting genes that are involved in the reduction of inflammation and the opening of the channels to promote iron influx to the circulation, which also helps in iron homeostasis and promotes better and more physiological production of red blood cells. In terms of treatment, the therapies that are under development are inhibitors of the enzyme that stabilizes the HIF, and actually this promotion of stabilization decreases the production of hepcidin, allowing for iron influx to the circulation, and also promotes an increase in endogenous ESA. There are some trials out there already. This is a summary of 2 of them on the non-dialysis space. The first drug is called roxadustat. It's a HIF stabilizer. And the first one was published last year in New England for Journal of Medicine. It's a small study looking at changes in hemoglobin levels after roxadustat versus placebo. And you can see here in the blue line that it increases over time, starting from a hemoglobin of 9 and ending the study with a hemoglobin about 10.5, which was very significantly compared to placebo. You see in the bottom of the slide the reduction in hepcidin and an improvement in the iron absorption. The biggest study published so far, or not published, but presented, was presented at the ASN this year. It was called the Olympus trial, again with roxadustat. And in this study, we actually randomized patients against placebo again. There's more than 1,000 patients in each arm. And the GFR for those patients are around 19 or 20 in both arms, so advanced CKD. And these are the results, which are very similar to the Chinese study, and this was presented very recently. And the safety data related to this was presented as a combination of 5 different trials, also at the ASN late-breaking clinical trial with no major signs of concerns in terms of safety. And this is what comes in the next few years. This is the number of new trials and new drugs in this space that will be finishing phase 3 trials in the coming years, and that just showed how much we'll learn about these new therapies. So these are my take-home messages. Anemia is common and harmful. I think this is quite clear, at least from observational studies. And attempts to normalize hemoglobin with the current strategies, iron and ESAs, have failed to shift the risk and benefit paradigms. Treatment strategies, they are focused on hemoglobin target, and I think we should really hear patients more and see what they would like in terms of outcomes. In new therapies, they open opportunities for changes. Thank you very much.